Medication Assisted Treatment by Dan Varley, Brian Hickey, and Kelly Clark. Today we're going to talk about methadone, which is a synthetic opioid used in medication assisted treatment to help people with heroin addiction and addiction to opioid painkillers. It acts as an agonist on the mu receptors in the brain, which means that it blocks the effects of other more powerful opioids like heroin. So when someone's on methadone, and they use heroin, they can't get high from it. The other benefits is it helps with the withdrawal process. It makes it a lot safer and with a lot less discomfort. Um, so methadone is a Schedule II controlled substance under the Controlled Substance Act. So it is something that can be abused and does have the potential for abuse. So the reason it has the abuse potential is its base effects are similar to that of opioids, feeling sedated, some euphoria, drowsiness, relief from pain, things like that. But it's not as strong as actual opioids. Side effects include the same things you would look for if you were looking for someone on heroin: pinpointed pupils, nausea, constipation, decreased heart rate, mood swings, um, overdose effects. So you can overdose on it. It does have overdose potential. You would see a decrease in blood pressure, decreased heart rate, trouble breathing and twitching, diarrhea, and cyanosis, which is that bluish tint that you might see on the lips or fingernails, extreme lethargy and confusion. So medication assisted treatment of methadone is first attributed to the Germans, actually, right around the time of World War II. But the U.S. government began using it down south in Kentucky and in Texas. Um, they in the Kentucky facility they did a study on using it for people with heroin, using heroin, and they found it was really effective, but they had really high relapse rates. As you can see, up to 90% of the people relapsed. So in 1964, Dolan and Neiswander started doing research, and they found that use of methadone as a maintenance would be ideal, and it lowered that relapse rate all the way down. The FDA approved it for treatment in 1972, and the Drug Abuse Treatment Act of 2000 made it easier for providers to treat people. So it also did add more documentation and certifications that doctors and medication assisted treatment centers needed to put in play to be able to do that. So methadone is also known as Dolafine, and it is administered under a doctor's care. And with that Data 2000 Act, facilities do have to be certified by the Substance Abuse Mental Health Services Administration. It's administered in pill, liquid, or wafers, but it's not meant to be the only treatment you get. So these opioid treatment programs, or OTPs, also do provide all these other services that someone in recovery from substance abuse would need: psychosocial groups, individual therapy, family therapy, vocational help, medical care. It's supposed to be a comprehensive look at recovery. Um, there are strict dosing guidelines, and those are set by federal and state statutes. But if someone is on methadone treatment and they're doing well, they can get doses to bring home, because one of the downfalls of methadone is having to go daily to get to. Recent numbers look at there's over 2 million people who are using some type of opioids in America today. Um, the demographics of the population, right, in early times, the late 60s, early 70s, predominantly identified as minority males in low income communities. Therefore, most methadone clinics, even still today around the country, are going to be found in low income urban areas. Um, when buprenorphine came out, uh, it's able to be prescribed now through private insurance. So there's implications of demographics there for methadone users. People getting buprenorphine can be, the demographics of that are going to be more white people living in the suburbs that have access to medical care, and prescribers that'll prescribe it. Whereas people who are addicted to heroin are still going to have to use the methadone clinics in the urban centers. So, according to a report by SAMHSA, methadone use rose from 227,000 people in 2003 to almost 307,000 in 2011. As with many substance abuse disorders and issues surrounding substance use, there's stigma surrounding medication-assisted treatment. Many people think that opioid addiction and any addiction for that is a self-inflicted condition. A lot of people still go with the moral model, that it's not a disease and that it's a choice. So people think that taking methadone is replacing one addiction for another. This unfortunately can even happen among the providers of social service agencies and friends, healthcare professionals. So there's a big influence on policy with that too. Criminal justice population have very limited access to the methadone and medication-assisted treatment. As a result, they have one of the highest rates of mortality on overdose among being released within 60 days. Of course, there's a lot of political opposition, and because of stigma, there's limited funding for programs that provide medication-assisted treatment. So some of this might be changing. There might be some, definitions of recovery that are starting to become more acceptable. But even among AA and NA groups, 12-step meetings, you'll find stigma. People feeling like because it is a narcotic that it's tough for people to really claim clean time because they feel like people are still using a chemical when they're using methadone. So although it's not widely around in America yet, there is a Methadone Anonymous group that was formed as a result of that stigma within the 12-step groups. So White and colleagues wanted to look at stigma surrounding these 12-step groups and to look at the outcomes for people who are doing 12-step recovery and medication-assisted treatment. They wanted to study to look at the long-term recovery outcomes. They did. They met with 322 patients within a substance abuse clinic with a structured interview. It was an anonymous study. 55% were male, 45 female. So the results: 24.4% reported having serious problems with AA or NA. Because of the stigma surrounding their status of someone who accesses medication-assisted treatment. So self-disclosure was low. There were high rates of reported helpfulness of AA-NA despite negative attitudes. And despite AA-NA exposure, patients also reported they failed to be fully integrated into the culture because of the way it's looked at when you're using medication-assisted treatment to try to get clean and sober. Yeah, there's a lot of internal stigma, self-imposed stigma that people feel when they're entering treatment. People from substance abuse recovery generally, but definitely individuals, receiving methadone because of the stigma that's attached to that. So some people will not enter treatment at all. Other people seem to leave treatment early. There's a low attrition rate for completion. And it also creates barriers to other healthcare related needs that they might have. So some of the things we can do to combat medication assisted treatment is, making sure people are getting their appropriate dosage levels. When people are dosed appropriately, they're going to be able to function better, and it's going to make their recovery more solid. Using integrated evidence-based treatment and doing those things I mentioned earlier, family therapy, individual therapy, cognitive behavioral therapy, other types of psychosocial interventions should be going hand in hand, and that will, help raise the inner efficacy of individuals receiving that and start to challenge that stigma at the public level as well. We want to improve knowledge among treatment providers also and continue to do research so that we can find out, what's the most effective way to provide medication-assisted treatment that'll have the best long-term outcomes. So overall, medication-assisted treatment demonstrates, that it's safe and effective when used with all these other appropriate safeguards. There'll be a reduction or cessation of people going back to the street to get illegal heroin, and it'll reduce their risk of overdose. There's a reduction in psychiatric symptoms, unemployment rates fall, and people can really start to begin to function again in society with their family and with their friends if their dosing levels are right and they're successfully completing the medication-assisted treatment. And part of that is going to be programs within the treatment itself, including, that take-home medication privileges, which is really important, because otherwise people have to go to the clinic 5, 6, 7 days a week to get their dose just to be able to function. Number one ethical responsibility as social workers is our primary responsibility to promote the well-being of our clients. So even though social workers can't prescribe, we have a lot of contact with clients, so we're in a position to make the right referrals, including for MAT treatment. Knowledge of MAT will, by the social worker, will definitely roll over into a higher level of care for a client. Social workers who have good attitudes towards medication definitely show a higher rate of effectiveness, and that's including belief in other modalities such as the 12-step orientation, abstinence, harm reduction, taking all of them and matching them with the medication-assisted treatment concept. So we have some questions related to the presentation. Question one, what are some of your considerations and thoughts on how medication-assisted treatment stigma can be addressed, either individually, locally, or systemically? Please provide examples. In what ways do you think MAT or OTP services can be improved, or what they can incorporate to enhance recovery outcomes for patients? Do methadone and Suboxone have psychoactive effects on an individual? That's question number 3. And number 4, what are the main differences between methadone and Suboxone medications? Thank you for joining our presentation today.